Welcome to this video on the pharmacological aspects of organophosphorus poisoning. Now, in previous videos, we spoke about the classification of anticholinesterases, otherwise called cholinesterase inhibitors. We discussed that these drugs are highly cholinergic, and we also spoke about the organophosphorus compounds and how they are classified, rudimentarily at least. Now, organophosphorus compounds are commonly used in the agricultural industry as insecticides and pesticides. Poisoning is fairly common. Now, we discussed in previous videos that acetylcholine is normally degraded by the enzyme acetylcholinesterase, and that acetylcholinesterase has got an anionic site and esteratic site, and that both sites should be free for it to be able to degrade acetylcholine. If any one or both of these sites are blocked, then acetylcholine will not get degraded and it accumulates in the plasma. Now, this is exactly how organophosphorus compounds work. They bind to the esteratic site, leading to an uncontrolled release of acetylcholine. Now, this excess amount of acetylcholine will then bind to muscarinic receptors and to nicotinic receptors. And these results in the symptoms of acute organophosphorus poisoning, which is a medical emergency. A common mnemonic which is used to remember the muscarinic adverse effects or the muscarinic effects of organophosphorus poisoning include sludge, salivation, lacrimation, urination, diarrhea, GI upset, and emesis, together with 3 B's: bradycardia, bronchospasm, and blurred vision with a pinpoint pupil. The cause of death in these patients is usually due to respiratory paralysis, and this is mediated by overstimulation of the nicotinic receptors by acetylcholine. Now, there are certain general measures that need to be taken when a patient presents with organophosphorus poisoning. If the patient has been exposed to it by coming into contact with it with his or her skin, then the contaminated clothing should be removed. The skin should be washed with alkaline soap, and the healthcare professionals who are doing this should take precautions themselves, because they can come into contact with the poison, and therefore they should be using personal protective equipment as suitable. Now, regarding the pharmacological management of organophosphorus poisoning, the drug of choice by far is atropine. Cholinesterase reactivators also have a role to play in the management of organophosphorus poisoning. Now, we saw that organophosphorus compounds bind to the esteratic site, causing acetylcholine to accumulate uncontrollably, and this acetylcholine will bind to both muscarinic and nicotinic receptors, causing both the muscarinic and nicotinic symptoms of organophosphorus poisoning. Atropine, being a non-selective muscarinic blocker, will block the muscarinic symptoms of organophosphorus poisoning. So it is a non-selective muscarinic blocker, and it is an anticholinergic drug. It has little clinically significant effects on the nicotinic receptors, and hence it will block the muscarinic symptoms but not the nicotinic symptoms. Now, it's worth talking about the respiratory symptoms in organophosphorus poisoning. There are some respiratory symptoms which are mediated by M3 receptors, muscarinic receptors, and some which are mediated by nicotinic receptors. For example, bronchorrhea. So bronchorrhea occurs due to excessive production of secretions by the glands in the respiratory tract. We know that M3 receptors are present in the exocrine glands. We also know that M3 receptors are present in the bronchi, and upon stimulation it causes bronchoconstriction. Both these effects can effectively be blocked by atropine. However, the neuromuscular blockade that results in diaphragmatic paralysis and loss of respiratory drive are both mediated by overstimulation of nicotinic receptors, and atropine will not be able to block those symptoms. So bronchoria and bronchospasm do respond to atropine. However, neuromuscular junction failure and therefore diaphragmatic paralysis and loss of respiratory drive fail to respond to atropine, and therefore patients must be intubated and ventilated till respiratory function returns. As discussed earlier, atropine represents the cornerstone of the treatment of organophosphorus poisoning. And how much do we give? Now, the recommendations are different. So we shall discuss two important recommendations. The recommendations put forward in the most authoritative pharmacology textbooks and the recommendations put forward in the toxicology textbooks. So both agree that we give around 2 to 4 milligrams of atropine initially, and we give it by the IV route. Although IM is also acceptable, the preferable route is IV, and we continue giving 2 milligrams of atropine every 5 minutes until muscarinic symptoms disappear or signs of atropine toxicity appear. More than 200 milligrams may be required on the first day. Once targets have been achieved, we maintain a mild degree of atropine block. An alternate regimen would be to give an initial bolus of 1 to 2 milligrams and with subsequent doses doubled every 5 minutes until atropinization is achieved. There is a fair bit amount of arguments and evidence that seems to support this alternate regimen. Target endpoints for atropine therapy include a clear chest on auscultation, a heart rate more than 80, systolic blood pressure more than 80, pupils no longer pinpoint, and dry axillae. At least 4 out of 5 of these criteria should be satisfied, out of which the first 3 are mandatory before we consider a patient to be fully atropinized. So these are the two regimens that are recommended for the treatment of organophosphorus poisoning with atropine. Now, regarding cholinesterase reactivators, otherwise called the oximes. Again, we know that organophosphorus compounds act by blocking the esteratic site of acetylcholinesterase enzyme, and this causes acetylcholine to accumulate and cause a cholinergic crisis. Now, it is possible to administer oximes. They bind to the anionic site, they form a bond with the organophosphorus compound, form a complex, and they remove the complex en masse. And this basically reactivates the acetylcholinesterase enzyme. Both sites become free, and acetylcholine can now bind to both sites and get degraded. So that's the basic mechanism of oximes or cholinesterase reactivators. The examples for oximes include pralidoxime and diacetyl monoxime. Now, regarding the use of oximes in carbamate poisoning, past recommendations suggested that oximes were contraindicated in carbamate poisoning, but these recommendations have been removed. It is true that if administered alone, oximes have been shown to worsen outcomes in carbamate toxicity. But this is true only for one type of carbamate toxicity. That too, if oximes are administered alone, that is for carbaryl toxicity. But even in carbaryl toxicity, if the oxime is administered with atropine, survival is improved. Thus, the current recommendations clearly state that pralidoxime should never be withheld in a seriously poisoned patient out of concern that the cholinergic drug might be a carbamate. However, it is strongly recommended that pralidoxime should always be used in conjunction with atropine, and that it should never be used as the sole therapeutic agent. Now, we need to be familiar with the concept of aging. Now, in a patient who has suffered from OP poisoning, after a period of time, some OP compounds can form a permanent bond with the cholinesterase enzyme, and this bond, once formed, cannot be reversed by oximes such as pralidoxime. This happens in a process called aging. Carbamates do not age. The time it takes for cholinesterase inhibitor bond to age varies. For example, for soman, it is hardly 2 minutes. For sarin, it takes 5 hours, and so on. As a general rule, 2-PAM has to be given within 48 hours of the onset of poisoning. Otherwise, aging would prevent it from working efficiently.